Any problem at the technical level?
None so far.
Okay, thank you.
You're welcome.
So if I assume that all of us one day or another are going to be sitting on the right hand side of this slide, one of those orange bubbles, one of those EF projects, be national, be regional, be in a city, in a community, and we are trying to interconnect a significant number of systems, point of care, and other public health systems in those projects. We are now definitely looking toward the left, and we are looking at the world of standards that we need to consider and bring together in an orderly way. And the logos that I'm showing here are only a small number of those standards. They may be the most well-known standard that we have heard about, but this is not the complete list. Many e-health projects have told me that you need anywhere between 20 and 50 different types of standards pulled together in a correct specification that is then implemented, then deployed, and for which you need an adoption process in order to make information flow. Essentially, what AeHIN and Continua, who is working in the home patient care device space, is trying to do is to say, yes, each project can actually cook and bake and assemble a specification based on those standards. Some projects have the skills to do that. Some projects have some skills, but maybe not sufficient skills. And some projects may not have the skills. Whatever is your skill level, this remains a challenging task, a task that requires a high level of expertise, and a task which is often difficult because many of those standards are overlapping, competing, have not been designed in a sense to fit together very well. Some people say we should restart everything. My answer is no, it's too late. We need to make the best use of what we have done. There is too much investment. So this is where AeHIN came about, which is to say, can I have an internationally driven process where I take known problems in e-health interoperability and agree on a solution that assemble those standards for a specific problem in a specific cookbook, call it an implementation guide, call it a profile, call it a specification, an interoperability specification. Many terms there are used, but essentially we're going to mediate between the projects and the standards. Why? Because we are trying to get some common things across those projects. E-health projects die of having too much elements that are specific to the project. Some of them must be specific, but actually no more than 5 or 10%. 90% of interoperability in e-health projects across the world could share close to common specification. There is not that much variety at the 90% level. Yes, we need flexibility for the remaining 10%, but why don't we address our 90% of common specification? So we call this intermediate word called profiling and profiling organization. That's how the Gartner Group is now calling them. This is the term that is used in ISO, for example, for AeHIN and a number of understanding of the difference between the standard development and the standard profiling organizations. So once we have understood this, the question is, how do we go about doing it? And essentially, when AeHIN says, hey, this needs to be a multi-stakeholder process. It cannot be done alone by the vendors. It cannot be done alone with the clinicians. It cannot be done alone by the academics. It cannot be done alone with by the health authority. It cannot be done alone by consulting firms and so forth. So bringing those stakeholders together and putting them around a table where they bring consistent specification or coordinate the implementation of standards is essentially what AeHIN is trying to do, and trying to do this at the international level. Why international? Is because we think that the economics of interoperability in e-health require international consistency at a good level. Not at 100% level, but at a good level, because this is going to create common software, common test tools, common skills, common training, common education of the health IT workforce, and so forth. This is preventing more fragmentation than we already have in the world of healthcare. So in short, AeHIN is attempting to be a forum for agreeing on how to implement standards and a process on how to make this adoption and this implementation happen. So that's the thought, the strategy, the major goal that AeHIN has set for itself. So let's move now to an example. As we've positioned a little bit in the large world of e-health, the focus that AeHIN wants to keep and have, which is e-health interoperability, technical, semantic level, international in scope, and make this standard adoption process as efficient and simple as possible for developing countries, but also for developed countries. So the example here is a very classical example. A patient goes from a general practitioner to a hospital, back to his doctor, to a specialist, back to a hospital, back to and now to long-term care. Classical path through various settings in the health system. As one traverses this healthcare setting, systems, care delivery, point of care, pharmacies, and on and on and on and on, you leave behind you a number of information, and each piece of information, those red simplified dots that are shown here, that a lot of structure information is there, are collected along the way, and a thought that was proposed in AeHIN back in the mid-2000s was to say, could we essentially have an index of this information which is in existence throughout an existing environment in healthcare system? We could leave the information distributed, we could centralize it. Both models need to be supported, but conceptually, this is an example of a profile that has been proposed to AeHIN that says, hey, could we define those dotted lines so that the interaction between a source of data and an index that is indexing a longitudinal record could be standardized so that one entity could query for the index, get information, and be able to pull the information of relevance, of interest, from wherever that information is stored and bring it to the point of care or the point where it is needed. So we see here typically an interoperability problem that has been presented to AeHIN, and AeHIN saying, okay, what are the standards we should use to submit those piece of records? We call them documents here, but view that as a record those records? How can we retrieve them? How can we query them? What are the kind of discovery and queries and metadata that is needed to actually make this work? I'm giving you here one example of one problem with one solution that AeHIN has developed. And this is called in AeHIN lingo XDS for cross-enterprise document sharing. And we use the word document here in a way that a doctor would understand it. That between IT people, we need to realize that those so-called documents are actually an object, a record that contains structured information. That could be a little bit of structured information, or that could be a rather complex and extensive amount of structured information. But it could also be highly unstructured. In the simplistic case, maybe it's a PDF. So we say, hey, we would like to move and share content of a variety of form and style and of standards, and have a profile that tell us and give us all of the transactions so that we can have information flow back and forth between those sources, those repositories, those document registries, and so forth. I don't want to dive deeper here, but I'm giving you an example of one AeHIN profile, and there are 120 of those, probably more like 130 or 40 now. Each problem, we call it a use case, and this use case has a corresponding specification, which is called a profile, which is a document that is pointing at the standards and subsetting very precisely the elements of that standard that is needed for those each one of those transaction or services or exchange, whatever conceptual term people want to use there. So that is the thought. So what kind of a process do we need to actually make this happen in a consensus build-up way? The process that has been proposed is to break this process into a part which is done internationally, a part which is done at the national level, and I'm showing here AeHIN Europe, but you could put, instead of AeHIN Europe, you can put AeHIN AeHIN at a regional level, where there are things that you share in common and that you would like to do and to pull your resources together. So let me show you what is done at the international level. First, document use cases, those are those requirements, and actually prioritize them. Every year, we have a process to review a number of submissions and pick a reasonable number of those and say those are going to be the focus for the year to come, and those are the problems that are going to be solved, the profiles that are going to be created. Once we know very well the problem, and only then, standards are being selected, sometimes easily, sometimes with much debate, because there are competing standards. Sometimes we have a lack of standards, and we need to say, nobody thought about that. This is a gap. Why don't we talk to this or that standard development organization? Why don't we go to ISO? Why don't we go to HL7? Why don't we go to DICOM? And so forth, to SNOMED, to whatever, depending on what the gap is. And that's assuming there is no gap. We can identify the standards, cook and bake them into a technical specification that I actually call a technical framework. And the technical framework is a book in which you find a set of profiles, those 120 plus profiles. Having those specs done, AeHIN would basically be more or less useless. More paper, another layer on top of the standards that are already a lot of paper, that would not help a lot. So AeHIN decided that unless this is actually implemented and tested, it has very little value. So we're going to take those profiles and we're going to organize connectivity marathon. And those connectivity marathons are going to be organized not at the international level, but at the national or actually at the regional level. USA and Canada do their Connectathon together. Europe, essentially Western Europe, do their Connectathon together, including all the way to Turkey. So it's Europe in a pretty broad sense. There are beginning of talks of Connectathon in the Middle East. There are Connectathon in Asia that are the tendency to be more country-specific, Japan, China, and also on the Australia, New Zealand side. So regional with a few exceptions depending on the politics of the set of countries. Then what has been achieved needs to be demonstrated. The users need to see it, the vendors need to be proud of it, and it needs to be shown in exhibitions. The next one being actually 2 weeks from now, which is HIMSS in the USA. They're going to be the largest booth at HIMSS is the IT booth, where we will see probably 60, 70, 80 systems from 50 vendors, all interconnected and paying about 20 or 30 of those 120 profiles that people will be able to see demonstrated and actually working and being offered to the market. If products are built, then those products can be actually installed in whatever project, whatever setting, whatever hospital where they need to be deployed, and they are easier to integrate because they have been built to a common profile spec based on standards, and they've been tested. Therefore, we have maybe not solved 100% of the problem, but solved a good number of problems, making the integration much easier. Clinicians, users, patients will have more timely access to the information, authority as well, and then we'll be able to actually restart this process, because as soon as we solve 1 or 2 or 3 problems, guess what? People understand it better and say, and what about this? And what about that? And that's why this cycle is happening in IT every year. A new set of requirements, new specification, new testing, and then made available for the deployment. The benefits are for providers, for health authority, for vendors, of having a more consistent marketplace. And for standard development organizations, they have their work, their hard work, being and moving into the real world in an orderly way. It may not be all of their standards. Some standards will remain orphan with very little adoption. Other parts of the standard will have a lot of adoption. That's the way the world is, and we cannot, and IT tries to be neutral and fair to all of those standards creators by respecting their work, using it in a correct way, an intended way, but also recognizing that at some time, at some point, choices have to be made, and not making those choices is actually preventing those standards from being deployed. So this is where IT is today. There's actually a couple more of those, what we call domain. A domain is actually a committee that is receiving those requests for problems to solve, and is producing those profiles and advertising them and organizing the testing downstream. And they are not all areas of healthcare are being addressed, but most of them. Radiology, cardiology, laboratory, oncology, patient care coordination, very important that all of the information that is not specific to a specialty, but that needs to flow among various care settings. Patient care device, quality research and public health, another set of information that needs to flow across care settings, but not to deliver care, but to produce research, to produce a quality measurement, and to manage a public health. Eye care, pathology, pharmacy. I'm not showing here 2 new domains that have been created. One is on endoscopy and surgery, and the other one being dentistry. They have not produced profiles yet, but they are now started, and they will deliver that next year. In the middle, the IT infrastructure domain that is building all of the common profiles that are the infrastructure, the terminology, the patient identification, the security, the privacy, that is spanning all of the movement of information whose content is defined around. patient care device is closely working with Continua. For those of you who know the Continua Health Alliance, with also international, also in profiling and doing home device type things. And guess what? They also adopt IHE profile so that we can connect the home device to doctor offices and hospitals and maintain a continuum of care. So that's where we stand. I would like to stop for a minute here before moving into the testing part of IHE and see if there are any questions.
Any questions from the participants? If not, I would like to ask one question, Charles, if possible. You mentioned that there are some standards that have been adopted by many countries or organizations, but others are not very widely adopted. So my question is, which ones are most adopted and which one is less adopted, and how is or why many countries or organizations are different on adopting this kind of standard?
Ooh, this is indeed a very vast question, but essentially, to me, the fundamental question, the question that is actually preventing progress in the standards adoption. There is not a simple way to answer your question. There is not a simple way for any project to see clarity. If you listen to the people from HL7, they're going to tell you that everything they did is wonderful. If you listen to the people of SACOM, they're going to tell you that everything they did is wonderful at solving world hunger, and on and on and on. And therefore, this is essentially one of the challenges that IHE is trying to meet here, is to say, in a neutral forum, where we're going to be able to actually not tell people which is a good standard, which is a bad standard. I believe that does not exist. The problem is, once we know what we want to do, some standards are better fitted to solve a certain problem than others. The universal standard in healthcare does not exist, and in my opinion, will never exist. This is a dream. This is healthcare is so complex, so varied, so by nature fragmented and specialized, that this is a reality that we better face rather than wait until consistency has happened. So if you want an answer to this question, we can dive into a specific domain, then we will really get the answer at the level of a specific profile. I can give you an example. Provider directory, people and organization director. IHE was asked 2 years ago to standardize a provider directory and all of the transactions. We looked around and we found that there were some general IT standards that were lacking health-specific content, typically LDAP and those type of standards. We had very specialized healthcare standards, like HL7 version 3, that were doing all of the transactions for a directory. And we had to evaluate both of those and say, do we prefer to be more IT generic and do a little bit of healthcare customization, or do we prefer to be very healthcare specific to the risk of having to build and reinvent a lot of software and a lot of things? After much discussion, much analysis, the choice ended up on the side of LDAP and of extending LDAP into the healthcare domain, which is very much in line with what ISO TC215 is pushing and recommending. So this is a case where I cannot say that one of the two is bad or good. A choice had to be made, and IHE made that choice in a collegial way, in an open way, in a way that took into account the perspective of many countries and many projects around the world. This was not an easy choice, but the choice was made.
Okay, Charles. But thank you. And we have two questions on queue. First, I would like to give opportunity to Mark for your questions. Please welcome, Mark.
Hi, thanks, Anis. I appreciate it. Charles, Mark Landry with WHO in the regional office in Manila. IHE was part of a meeting in December on a global forum on standards and interoperability held in Geneva. Now that you've had a time to reflect on that meeting and some of the next steps, I'm curious what role you see WHO playing as it relates to what I believe is very good and productive work of IHE supporting countries. But how do you see, after that meeting, what WHO's role could be to help IHE and ultimately to help countries implement standards?
Mark, I'm so glad you are on this call and you're asking this question. Actually, we discussed that point in 2 months ago and last month, because we took on that question early January, and then early February we asked again the question, and we are, in a sense, a little handicapped because we were waiting for some form of a summary or meeting notes or minutes or something that comes out of that meeting, and we have not seen anything, and we were waiting for that information to be available to truly digest it and try to come back to WHO with a proposal. So we've been waiting for something we should not have waited for, but that's a little bit where we are today. Do you know if there is any kind of summary or output that is going to be, even in some draft form, going to be produced out of this meeting, or should we simply use our take-home from that meeting and try to make some kind of a proposal?
At this point, I would recommend just receiving a proposal from you, but yeah, I wouldn't wait. But I'm just curious if you've had any suggestions for us that maybe you didn't share at that meeting. I don't want to take over this discussion today because it's more important that you proceed, but I just wanted to understand from your view how we can assist with this critical issue that clearly this presentation is about, how to help countries implement all of these important standards.
Okay. Honestly, I believe that the main thought, without being specific, is clearly a step on awareness, education, and a methodology. We have a lot of methodologies that have been developed for IT projects. How do you architect, how you design software, how do you test software. This is a very well-developed field. However, the field specific to e-health interoperability and the complex world of standards that we need to leverage is a world where we don't have a good methodology. So I would say the first contribution that IHE would like to bring is to provide a forum where we discuss where and how do we apply the learnings that we've had within IHE and how the countries that have already deployed IHE profiles have learned as to what they ought to do. And this is one thing that we are doing today, which is to truly understand what does it take to actually get a project going, focusing solely on interoperability. I will give a little bit of hint on this. I have a few slides because this is a topic that I discuss with many ministries around the world. I'm actually in Saudi Arabia because I'm helping the National e-health project there to organize their work so that they actually leverage IHE. And they are finding that they do not necessarily understand easily how to do that. It's easier, but it's not yet sufficiently easy. So I would say this is definitely something in which IHE would like to progress, and doing this with the support and the input and collaboration with WHO would be definitely a great thing. We have, and I will speak to this in Istanbul in April, an IHE World Summit. It's actually the first time we bring everybody together in a World Summit, and this is going to be one of the topics in that summit. So maybe we can have a further conversation on this, either in this forum or in another, as you see fit.
Excellent. Thank you very much for that input. Thank you.
You're welcome.
Thank you, Mark.
There was another question.
We have another question from Dr. Jay.
Yes.
Dr. Jay Mohan, please.
Hello. Hello,
Yes,
this is
hello.
Jay.
Yes, please.
Hey, Charles. I have posted the question in the chat. Is there a repository or evidence base on successful adoption of IHE profiles in the developing world? Especially, I'm interested in the Asian region.
Okay. I will speak to this in a later slide.
Okay.
There is some information, but probably not sufficiently organized. And
Okay.
that's definitely something that a collaboration with AeHIN would definitely help. It is very
Okay.
hard to organize this information, and you need both the consumer of it and the provider of it to kind of talk to each other. You know, this is a characteristic of national programs. They are very good at managing the politics inside the country, but they are very bad at understanding how to relate to each other.
Okay.
And I know it's hard.
Okay.
Yeah. So let's move on. So in short, IHE offers a broad collection of profiles, far from being complete, but honestly, some people are saying there's already too much, give me less. No, pick the one you need, and the one you don't need, ignore them. There are profiles that are dealing with how do you share data, integration, content, how do you structure the data, how do you encode that data. On terminology, IHE is progressing at the speed where international terminologies are being adopted, and that's a little lagging behind. But we are pushing this envelope, if you want, but not trying to go too far, because we realize that internationalizing terminology is still a large challenge at the standard development level. So we're not quite yet at the profile and adoption level. Security, privacy, a lot of work here, especially centered on why don't we address the most common and basic security and privacy problem. Doing only this is going to be such a major contribution that we need to move in a stepwise way in this area, and IHE offers those steps. And we are now increasingly moving in workflow, especially in region or nationwide workflows that are far more delicate to handle and complex to handle than workflows inside the hospital. Workflow inside the hospital, IHE has been doing for 15 years. Workflow among entities is far more complex, and there are some novel ideas that are coming up here. So if you want to know what IHE has done so far, I give you the link below, and go and read what we call in the various domains, you know, those 14 domains. Read only the technical framework, volume 1. You will see the use case for each one of the profiles. You may dive in the one you're interested, looking into the following volumes, but pick the one you are interested. Don't get lost in the 120 from the start. In terms of adoption, we've seen about 5 years ago, Europe do a e-health interop, what we call the mandate 403, that explains why profiling is good and what does it mean and how to use it. I will show you a few slides of this. ISO TC215 has actually a technical report, 28380, that talk about global interoperability standards adoption and speak of IHE processes, IHE profiles, and the deployment, which is the one in development. So, and that's really something where an answer, in a sense, to Mr. Landry's question and some earlier question of how do you deploy interoperability in a project with some good principle, and that's what the part 3 is all about. If you're interested in this, send me an email or join the working group 2 of ISO TC215 where this work is being done. Mexico is the next place where we're going to actually issue the first version for ballot. So it's a good time to comment on this. And finally, an eHealth European Interoperability Framework that has that is for the time being a draft that tries to say, why don't we adopt some of the IHE profile and continue our profile at the European level and let the countries assemble them in each one of their projects. So we put the IHE as a European adopted set of building blocks, and the building blocks are being assembled by each project. We're not going to solve interoperability 100%, but we will solve it 80 or 90%. That's a step in the right direction. The mandate 403 in this picture really explain the problem. The problem is we get so many flavors of base standards and subset and options that it's easy to solve the same problem in different way, although it was the very same problem and it could have been solved the same way, with the same specification and the same subset of standards. So what is being proposed here is to create this intermediate layer where the profiles form pre-assembled blocks of specification. The idea here is to say, just like when you build a house, rather than building your house from the raw material, which is the base standard, build your house from those pre-made building blocks. Build your house from a industrial pre-made door, window, stairway, kitchen counter. Don't rebuild those from wood and sand and concrete. So this is the idea of the profiling, so that different projects, although in their project specification they may be assembling the profile, a slightly different mix of profiles, everything which is going to be done, which is one way, everything which is to be done, and if it is the same, they will likely use the same profile. So we're going to see commonality grow naturally among the projects, thus simplifying the writing of the spec, the testing of the spec, the testing of the implementation, and potentially any certification effort. Very, very important. And we solve a problem here, which is very obvious, is that you now have, and we think that to do an eHealth project of a large scale and very rich, 30 to 50 profile is all that is needed. However, you can feed hundreds, thousands of projects with those 30 and 50 profiles. And you hide the complexity of those 500 or 800 pieces of base standards that needs to be assembled. So that's the general concept of profiling. 120 profile, I told you, relevant domain. It's actually 14 now, but all of the last 3 have not yet reduced profiles. This is the list. We're not going to go through that list, but it gives you a sense of things that are done in infrastructure, in anatomic pathology, in cardiology, in eye care, in patient coordination, emergency, baby care, antepartum, labor and delivery, device, pharmacy, laboratory, radiology, radiation oncology, quality research and public health. So you get a sense of breadth here. You're not being cornered in solving only 1 or 2 of your problems. So how does IHE go about making this more than just specification? The idea here is to say those profiles are pragmatic. They can be applied now. And IHE is committed to make those profiles evolve if they need to evolve and when they need to evolve, and will make them evolve in an orderly fashion at the international level. We're not going to be producing new version of those profiles every year. There may be a new version every 5 or 10 years. Yes, it's going to move a little slowly, but we're going to manage the speed at which it moves. Because changing interoperability is a very, very painful exercise. So we need to make sure that when we change because we have a good and necessary reason. So the thinking here is we think like a project which is deployed. We don't think like a standard developer which says, hey, you know, I fixed a few things, new version, new version, new version. You know, how many version of HL7 V2, how many version of HL7 RIM, and so forth. No, we want to manage this, control this, we move, we change because we need to change. Those things can be configured, and they are intended to address broad constituency, ranging from public health to patient control record, to electronic record, and so forth. So, it's this consistency, in a sense, which is the key motto inside G. You see the process here, and there is one critical element, which is the testing. In AeHIN, you cannot publish a profile unless it has been tested successfully by at least 3 different implementations into 2 different continents in the world. So you must have 3 different implementations in America and 3 different implementations in Europe or in Asia. And if you have that, 3 and 3, it makes 6. They are completely independent. They've been done very separately, and they work together. Then the specification is good enough. We have vetted that it does what it is supposed to do. It can be implemented, and it can be implemented in an interoperable way. So the Connectathon is a very complex and very subtle exercise. It has taken, and every year AeHIN is perfecting, improving its Connectathon process. The Connectathon is open to all. It uses tools that are very advanced. How do you test 120 systems in 4 days or 5 days, all in the same room, with about 500 people running the testing? This requires advanced processes, good tools, and a lot of discipline and of processes. Supervision, because you need to grant passing grades or not out of the Connectathon. There is a whole project management team, mutual experts that are grading the test. We managed to run thousands of tests in 1 week and make sure the results are recorded and published. AeHIN publishes only the successes. So if a vendor, if an open source developer brings this implementation for 1 or 2 profiles, tests it and fails because it's not ready, this is not going to be published. Why? Because we want the same implementer to come back to the next Connectathon and succeed. So the culture is for success, and we reward success, and we never punish a failure. We actually help people solve and address and get beyond their failure. So this culture of collaboration is critical. It is amazing to see how this happens, how engineers from competing vendors and software developers having completely different commercial models based on open source or proprietary things and what you want, all kind of agreeing that they need to work together and achieve compatibility and testing of their implementations of the AeHIN profile. This is a picture of the testing session that was held a couple of years back in Pisa, Italy. The European Connectathon travel, I said that it was going to be in Istanbul, mid-April. There was a Connectathon in Chicago 2 weeks ago in January for Canada and North America. There's going to be one in China, I think in May, June. So it happens all over the world and is a great opportunity where you actually test and test the spec as well as test the implementation. So you see Istanbul, Turkey, April 15 through 19, 2013. Results are published, I said that. So I think you get the sense of now of a framework that is not only that start from the standards and that finish with working software tested for 1 profile. Now, when you are a project, how do you use those AeHIN profiles? I'm sitting here, I'm the head of a national or regional project in country X. I have some objectives. I have some use cases for which I want interoperability. I've been told you need to share patient summary among hospitals and physician offices. Okay, that's my interoperability use case. How do I go about doing this? I go about doing this by selecting profile so that I don't have to dive into the standard detail. I simply have to pick the profile and say, okay, what profile do I need for services? I need to manage patient demographics. I need to share my patient summaries, document sharing. I need a provider directory so that I can name which is the provider which created or updated this summary and identify it in a consistent way. I need some content for my use case. So I will create this orange specification that instead of being 1,000 pages of detail that are going to be completely unique to your project, it's going to be a 20-page specification that is going to actually point to AeHIN profile, explain how to assemble them, and fill the gaps that are specific to your country. I'm sure you have the patient identifiers in your country versus another country is going to be of a different structure with different rules, so that is going to require gap filling. As a result, this orange specification is going to be something that, although I do not understand anything as to what is ES in your country, I'll be able to read it and say, oh, they use this and this and that profile. Okay, oh, here they have some extensions. I will know the extension you do very clearly. So it's easy for the vendors to read. It's easy for the people doing the testing. It's easy for the people that have to do the training. It's easy to deploy the system. So we are streamlining this way by reusing those profiles, those building blocks, the whole process of going from the standards to working connected systems. So that's the thought, and that, of course, is a spec that is feeding the interoperability testing. And guess what? You don't have to retest everything. You say, oh, this product is made of the 5 profiles I need. They've already been tested at this Connectathon. And the only thing I need to test is, are they glued together according to my orange spec? Have they done the extension specific to my country? So your testing becomes much smaller, becomes value add and specific to your environment, while you reuse what is internationally common in terms of building blocks. So a lot of streamlining, turning a project that would on average take 6 to 8 years into 1 to 2 years. Major, major, major saving. Major benefit for developing country, major benefit for other country, because believe me, interoperability is hard wherever you are in the world. So AeHIN has been created and is recognized and has an active chapter in a variety of countries. This is where we were. You see that one of the amazing things is that although AeHIN started in the USA, it then picked up very effectively in major countries in Europe, then went to Japan, then went back to the UK, then Canada latched on it, Taiwan, and then back to some European country and some Asian country as well. So the international nature was not obvious at the beginning. People told us you cannot have those profiles be global. And the answer is yes, it's possible. It doesn't mean that you don't need to do some extensions, but they are minor, and this has been proven over and over and over and over. Some profiles will never work in certain countries because of certain rules, but most profiles work into most countries, and we consider this sufficient success. Today there are 550 organizational members. The AeHIN International Board is going to accept AeHIN Saudi Arabia next week at HIMSS. So growing and actually moving clearly into the developing country space. So an example, and when you speak of adoption of AeHIN, you need to speak of the adoption of specific profiles. Some AeHIN profiles are very poorly adopted. Some AeHIN profiles are highly successful. Some AeHIN profiles on the path to success, but not quite yet widely adopted. So one of them that has been the most adopted is called SDS, the example I was giving you at the beginning, to create this shared record at the national level with open toolkits that are available from Open Health Tools, that means IBM, Microsoft, even those companies are providing the open source tools to support those IT profiles, and many projects in many states or regions or countries around the world, and this list is far from being complete. This is not even complete, but a little more complete. And I want to answer the question we had before. Experience in developing countries. You see South Africa on the left. They were probably the first one to do a deployment based on AeHIN profile. The deployment was very successful. The project actually did not succeed because the software that was used in the hospitals and in the clinics actually was not suited for the environment in which it was used. So very successful interoperability, but the systems that were deployed at the point of care were not suited for what people needed at the point of care. Not the fault of AeHIN. AeHIN says we're not into defining how software behaves for the local users. That this was the proof, and we were very happy to see that this model of interoperability could work in those countries. So, is AeHIN into the developing countries today? I would say a few, very few. Is it moving there? I would say yes, and I hope that this discussion we have will help you take advantage of AeHIN and enlarge, in a sense, the community and the dynamic that we have here. There is a website you can use. I can come back to EPSOS, which is the European project where we try to do cross-border traffic. And EPSOS is building on AeHIN profile, but more importantly, EPSOS is also reusing the Connectathon test tools as part of its internal testing strategy. And they are able to do their testing and move very quickly. Why? Because they are using the existing AeHIN specifications that they've assembled their way, but they're also using the test tools that they have extended to do their extension and support their extension. But that has speed up the project in an unbelievable way. And AeHIN has learned many, many things in terms of its tooling and how to support actual deployment beyond the Connectathon. The U.S. national backbone called NIN Exchange, now eHealth Exchange, with having a massive dynamic, and there are several distinct organizations that are now getting together as public-private entities. We'll hear more about this at HIMSS. But covering about 80 states, a large number of vendors, and having today about a couple million patients online and growing quickly, all built on AeHIN profile. I list here the name of the AeHIN profile. Please forgive AeHIN for creating those 3 or 4 letter acronyms for each one of their profiles. It's an acronym. You need to go to the spec to understand what XCPD does, or XCA, or ATNA, and so forth. So that leads me to, in a sense, a conclusion. What is the strategy here that would be useful? And this is really my thought, that I would like you to tell me whether they make sense or not. Reusing the specification building blocks. They are ready, they can be referenced, and they are maintained. So that is an assurance and something that is going to help you go faster with the sense of having already experience behind those. You have a large community that has the needed experience in implementing and testing, and you will go to join that community, even if you re-implement things yourself, because you want to own that software. This is perfectly fine. But you're going to leverage all of those benefits, all of those test tools, and go much, much faster. You have vendors, you have open source that have already been tested. So if you need those in part of your project, you can benefit from this. The cost of joining a Connectathon is about 3,000–4,000 euro for a full week of testing, and as I said, a large amount of tools and all of this. Vendors find this extremely cheap compared to the cost of suffering interoperability testing for weeks. In projects here, in less than a week, in a few days, they solve so many problems. The tools and everything in AeHIN is open. The specs are open. You can access them. You don't have a cent to pay. You can join AeHIN International. There is not a cent to pay. So no barrier of entry. The rule in AeHIN is you come, you work. It's free to come and work. You will work and learn with us. You will bring us your experience, your need, and this is going to benefit AeHIN and benefit you. So that's the general mindset and the thought of we will avoid reinventing. That's really what needs to be done. So in a sense, and in summary, and I don't want to dive deeper, but to tell you that this is a topic of discussion we could pursue at a further call, which is to say, what should you do in your country to leverage AeHIN profile? What is this rectangular orange thing where you recognize profile and you drive consistency into your projects across your nation? And I can speak to a number of countries that have organized this profile, this process based on AeHIN profile, and made it much simpler for interoperability, consistent interoperability adoption in their country. Please feel free to come to Istanbul if you can, mid-April. You will see the European Connectathon. You will be in shock when you see what's happening and the level of activity and the efficiency. You will meet real implementers. There is a first ever AeHIN World Summit on April 16 and 18, and I was mentioning that. It starts on the evening of the 16th and finishes at noon on the 18th, and we're trying to bring the AeHIN leadership worldwide. Will not all be there, but I would say sufficient representative for a lot of, I would say, substantive discussion with people that are using it in the trenches today. And I would say, you know, what does it mean to leverage AeHIN into a national interoperability strategy? I've not discussed that today, but this is, if you want and if you're interested, the topic of discussion that we could take going forward. I want to stop here and ask and answer a few questions, if any, in the remaining minutes.
Thank you very much, Dr. Charles, for your very fruitful inputs for our region. Are there any questions from our participants? If you don't have questions, or maybe you should just type it in the chat box. Dr. Charles, I would like to ask, how do you think would testings and connectathons at a regional level benefit countries from our region?
I think the answer to that, I can answer it with the European experience. What we are doing in Europe, we have 12 European countries that are together organizing the European Connectathon. And if you would ask anybody in Europe, can you organize a Connectathon at your country level? You would ask them in Germany, in France, in Italy, or even in the small country like Slovenia or Estonia. Everybody will tell you it's not possible. We don't have the know-how, we don't have the skills. We don't have the mass, the volume, the synergy to make that happen. And what the European countries have done is by, in a sense, federating into an AeHIN Europe, they are asking AeHIN Europe to organize this Connectathon. The tools in AeHIN are developed about 50% by AeHIN Europe. The remainder is done partly in the USA and partly in Japan. So by pulling countries together, you really solve three problems. You make something attractive to the implementers because they now see a bigger market. You are able to organize a single event and organizing it well with enough quality and enough expertise that you don't need to duplicate at the level of every country. And number three, you make it actually much more cost effective for the attendees and the people performing the testing and organizing the event. And of course, the impact for each one of the country is massive. I can tell you that the French national program, the Australian one, the Italian one, are benefiting from the Connectathon. They are actually sending their staff. So many of the Connectathon judges in Europe are coming from national programs. They are paid by the national program to be a judge. AeHIN doesn't pay them. Why are they there? Because the national programs need and want AeHIN Connectathon to be successful, to be well run, to be thorough, and they want their staff to facilitate this. So the whole idea here is it's in everybody's benefit to pool our resources. Even programs that have budget in excess of $500 million to $1 billion a year, they say we could not run a Connectathon if we wanted. Not because of money, because of the task, the process.